So my talk right now is going to be about the role of surgery in pleural mesothelioma. And as we've already covered, and Params described it beautifully, that the histopathological diagnosis would either be with a pleural biopsy, a fluid cell block, or in some cases, it mandates a thoracoscopic biopsy. And you need two mesothelioma markers to be positive and two adenocarcinoma markers to be negative to conclusively call it a mesothelioma. It's staged with a PET-CT, and most centers treating mesotheliomas prefer an invasive mediastinal staging to rule out contralateral mediastinal adenopathy, because that confers extremely poor prognosis in this disease. So the first question that we'll try to answer before we go into the details is, does surgery really help in this kind of a disease? And to answer that question, we have this graph from the SEER database analysis, which shows that all treatment combinations that involved surgery as a part of the treatment did better in terms of survival. So simply put, yes, surgery does help, which brings us to the next question, that when will you think of offering surgery to a patient with mesothelioma? The most important factor to consider here is the patient's performance status, because as we discussed, mesothelioma is going to have a combination of treatments, and you need your patient to be extremely fit to be able to undergo all these demanding treatment. Needless to say, non-metastatic disease and epithelioid histology with no contralateral mediastinal nodes, which in the case of mesothelioma are labeled as N2, are typically the best patients that you would choose for curative intent surgery. A lot of these patients, even with localized disease, come with effusions. What's important to understand is, if we have already established the tissue diagnosis, an asymptomatic effusion is best left alone. Do not intervene if the effusion is not symptomatic. But sometimes, like this scan shows, there are large symptomatic effusions which mandate drainage. And as far as possible, a thoracocentesis should be done to get the fluid out. If the effusion is too large and you cannot avoid a drain, what needs to be kept in mind that the drain site needs excision during surgery, because they're potential sites for tumor seeding. And the drainage of the fluid improves the performance status of the patient and may improve their chemo tolerance. Generally, any mesothelioma is operated after 3 or 4 cycles of neoadjuvant chemotherapy, which is generally pemetrexed and cisplatin based. But if it is an extremely early stage mesothelioma, there are reports of upfront surgery, and that is a reasonably acceptable strategy too, as long as R0 resection or a maximal resection can be achieved. The response assessment, like Param said, is with a CT or a PET-CT. And unresectable disease in cases of mesothelioma are disease that extend transdiaphragmatic into the abdominal cavity, the contralateral chest, or extensive chest wall involvement, which makes resection impossible. Any surgery for mesothelioma, whatever we pick, is extremely demanding, both for the surgeon, more so for the patient. They alter the physiology of the patient quite significantly. So a good functional evaluation cannot be more stressed upon. Pulmonary function test, DLCO, a perfusion scan to look as to how much the lung underlying the pleura is actually contributing to the patient's lung function, are of paramount importance. So is a cardiac evaluation. Optimizing comorbidities is important before surgery. Prehabilitation becomes extremely important at least 2 to 3 weeks prior to surgery in the form of physiotherapy and high intensity interval training. The types of surgery for mesothelioma were very elegantly classified by the ISLC. Partial pleurectomy and a simple pleurectomy decortication are procedures which are reserved in the metastatic or palliative setting. What we are more interested in is the curative intent surgery, which is either an extended pleurectomy decortication or an extrapleural pneumonectomy. An extended pleurectomy decortication, or an EPD, basically involves removal of both the pleural peels, that is the parietal as well as the visceral pleura, while maintaining the lung intact within the pleural cavity, whereas an extrapleural pneumonectomy does all this along with the removal of the lung. The diaphragm and the pericardium may be excised as involved. The lymphadenectomy involves a standard mediastinal lymphadenectomy that we do for non-small cell lung cancer. In addition to that, special attention should be paid to the internal mammary chain of nodes and the cardiophrenic and the costophrenic recessed nodes, because that's where pleural disease primarily goes to. This brings us to the very popular, famous Mars trial, which was headed by Tom Treasure, which looked at the role of an extrapleural pneumonectomy in the treatment of mesothelioma. It was a randomized controlled trial with 12 centers in the United Kingdom. To show a difference, the estimated sample size was actually 670, but this trial accrued only 50 over a period of 3 years. It required the mesothelioma to be pathologically confirmed, the patient fit for trimodality therapy, staged with a PET and a mediastinoscopy, receiving 3 cycles of platinum-based chemotherapy as neoadjuvant. This chemotherapy was not standardized, and the patient was then randomized into either an extrapleural pneumonectomy followed by hemithoracic radiation versus no EPP and continuation of chemo. When they realized that their accrual is going slow, they changed their primary endpoint to make it a feasibility study of randomizing 50 in 1 year. They took 3 years, so the primary endpoint was not met. The secondary endpoint was completion of therapy, morbidity, mortality, quality of life, and survival outcomes. Of the 24 patients randomized to the EPP arm, surgery was attempted only in 19. The remaining either progressed on chemo or refused consent, and the surgery was actually completed only in 16 patients. In these 16, the mortality was 16% and the morbidity 70%, which is staggering. And it's actually higher than most series of mesothelioma. 50% completed therapy. Most of these patients were actually ideal mesothelioma candidates. Good performance status, epithelioid histology, node negative. At 2 years, the median OS was 14 months in the surgical group, whereas it was 19 months in the non-surgical group, which was a little bit surprising. Quality of life wise too, patients who underwent an EPP actually did worse. So the authors concluded quite boldly that though the data is limited, EPP has no role within the trimodality therapy and possibly harms the patients. But this conclusion came a little bit fast and was faced with a lot of criticism, most famous being these 2 papers. Obviously, they pulled out the trial because of its poor accrual, the non-standardization of chemotherapy, and the extensive crossover between the 2 arms. So what this trial did establish is that EPP is morbid. There is a lot of mortality associated with it. But if you look at other series which reported on its EPP outcomes like Sugar Bakers or Raja Flores' series, the morbidity and mortality was quite all right, 19%, 6%. And they showed a median survival of almost 51 months in favorable patients, that is good general condition, epithelioid, node negative, R0 resection, which are generally the kind of patients that you would apply a trimodality treatment for. More than that, the ISLC data also said that EPP is probably better for early stage disease in terms of overall survival and recurrence. And the NCDB analysis also showed that surgery is very much important part of the treatment algorithm. EPP is a procedure fraught with risk. Pneumonectomy itself is a disease, a lot of hemodynamic instability, arrhythmias, SIRS, and a surgeon's nightmare, a bronchial stump blowout. This brings us to the more friendly extended pleurectomy decortication. The most important part here being that the lung is saved, which itself brings down the morbidity and mortality to almost 1/3 of that seen with EPP. But you need a disease that fits the bill. So this kind of disease, which is mainly effusion-based, response is amazing to chemotherapy. This looks like a normal scan. This is an ideal candidate for an extended pleurectomy decortication. This is not without its complications. Because you strip the visceral pleura of the lung, they are prone to have prolonged air leaks, intercostal drainage, which leads to empyema. Arrhythmias and SIRS are a part of this procedure as well. To put this procedure in a randomized setting, we have the MARS-2 trial, which was designed by Eric Lim and is currently accruing, which looks at 2 cycles of chemotherapy randomized to EPD versus no surgery, followed by 4 cycles of chemotherapy. It's accruing much better than the MARS trial, and the results are eagerly awaited. So all surgeons who operate on mesothelioma say that wherever possible, a pleurectomy decortication should be the way to go. But then again, once in a while, you come across such disease where despite chemotherapy, the disease is infiltrating into the lung parenchyma, and you're left with no other choice but an extrapleural pneumonectomy to get a maximum complete resection. So the International Mesothelioma Guidelines gave that all patients should be discussed in a multidisciplinary clinic. Histology and the nodal status should be identified prior to therapy. A macroscopic complete resection is the aim. The type of surgery actually depends on the type of disease and the expertise of the patient. Surgery again comes in effusion management in the palliative setting, where the fluid can be tapped, drains can be inserted, indwelling pleural catheters can be kept. Pleurodesis may be performed, but is not very effective because of all the pleural disease, and pleurectomy decortication only in very select cases. Two randomized trials in this setting, the Mesovats compared pleurectomy versus talc pleurodesis, found no difference in survival. The Mesotrap is still accruing, which is looking at partial pleurectomy versus indwelling catheters. I'd like to conclude by saying that mesothelioma is a disease that needs a very nuanced management with a multidisciplinary team. Surgery still offers the best survival, and we need to identify the potential surgical candidates extremely early in their disease. The best outcomes are seen with fit patients with epithelioid histology and node negative disease. The choice of surgery, EPP versus EPD, depends on the patient profile, the kind of disease that the patient has, and this operating surgeon as well. Thank you very much. I'd love to take any questions.